This is a See Jason podcast, and I am Scott Weiss, a pediatric intensivist from the Children's Hospital of Philadelphia and University of Pennsylvania Perelman School of Medicine. I am here with my colleagues and co-authors, Dr. Fran Balamuth, a pediatric emergency department physician, and Dr. Ben Laskin, a pediatric nephrologist, both also from CHOP and the University of Pennsylvania.
Hello.
Hello.
It is our pleasure to discuss our recent study titled Major Adverse Kidney Events in Pediatric Sepsis. Sepsis is a life-threatening organ dysfunction caused by a dysregulated host response to infection and is a common cause of critical illness in children. Acute kidney injury occurs in up to 1/3 of children with sepsis and is a consistent risk factor for adverse outcomes.
In this study, we determined the incidence of major adverse kidney events in children with sepsis and validated this concept as a potential outcome for future clinical trials. Major adverse kidney events, or MAKE, is a composite outcome that includes death, new dialysis, and persistent kidney dysfunction. We conducted a retrospective observational study of children between the ages of 6 months and 18 years admitted with severe sepsis or septic shock between January 2007 and December 2011 at 6 children's hospitals in the United States. The primary outcome was the incidence of MAKE events at 30 days or a hospital discharge, whichever came first, referred to as MAKE 30. The persistent kidney dysfunction component of MAKE was defined as KDIGO stage 2 or 3 acute kidney injury with at least a doubling of baseline creatinine that persisted out to either hospital discharge or 30 days from admission. Next, we validated MAKE 30 against all-cause mortality at hospital discharge, hospital length of stay, total hospital costs, hospital readmission, and lower estimated glomerular filtration rate in the period between 3 months and 1 year after discharge.
The study included 1,685 patient encounters. Acute kidney injury occurred in 31%. MAKE 30 occurred at 161 encounters, yielding an incidence of 9.6%. Patients with major adverse kidney events were more likely to die and had higher hospital costs, despite no differences in length of stay, than those without MAKE 30 after controlling for potential confounding variables. 452 survivors, or 29% of the total study population, had follow-up data available beyond hospital discharge. In this subset, those with MAKE 30 had no difference in readmission rates within 1 year, but were 4 times more likely to have an estimated glomerular filtration rate less than 60 mLs per minute per 1.73 meters squared by 1 year after discharge.
Our data provide the first evidence that major adverse kidney events, including death, new dialysis, and persistent kidney dysfunction, are common, feasible to measure, and linked to patient-centered outcomes in children with sepsis. Thus, we propose use of major adverse kidney events as a promising endpoint for future clinical trials in pediatric sepsis that seek to test therapies biologically mediated through the kidney. We would like to close by thanking the Clinical Journal of the American Society of Nephrology for their peer review and opportunity to share our work.
This podcast is copyrighted by the American Society of Nephrology, all rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare provider if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast of the American Society of Nephrology.